presentation from Amrita Institute of Medical Science. And presenter is Dr. Mohammad Nifsan Yusuf, is a MD Medicine resident, and moderator is Dr. Anup Menon, Assistant Professor Medicine on Amrita. I invite Dr. Anup Menon to come and moderate the session.
Good evening to everybody present here. I'm Dr. Nifson. I'm a first year resident from Amrita Institute of Medical Science. I'd like to thank API for having me. This is my first presentation here. My topic for today is a pivotal role of history taking in modern medicine. So in this world of new advances, modern medicine that's happening, newer investigations, genomic studies, but how feasible is all that compared to the traditional methods where we go based on a history and clinical examination? So I'd like to share a small case that we came across, which was a little interesting from our point of view recently. So, giving the biodata of this patient, she was a 74-year-old female. She is a known case of diabetes, hypertension, not on regular medication. She's a drug defaulter. She's a homemaker by occupation, and she weighs around 90 kgs. She's an obese female who's a known case of diabetes and hypertension. So she initially presented to the hospital with an alleged history of slip and fall on the 14th of July. She complained of pain in the left hip and thigh. There was no history of any loss of consciousness, no history of any tonic-clonic movements, no history of any syncope, or no history of any bowel and bladder incontinence. So she was born to the Amrita Hospital at the casualty. She was seen by the orthopedic team and she was admitted under them. So at the initial presentation, her vitals were as follows. Pulse rate of 100 pp, saturation was stable. There was no spinal tenderness, no visible head injury. CNS examination, her GCS was E4, V5, M6 with no focal deficits. And other systemic examination was also within normal limits. So she underwent a procedure on the 14th of July. She underwent a proximal femoral nailing, and subsequently, over the next 3 to 4 days, her labs revealed hyponatremia. The patient continued to have some fever spikes in hospital, along with urine revealing numerous pus cells. So they had taken a consultation from general medicine, and we had started the patient on cephalosporin sulbactam. And over the next 2 days, the inflammatory markers were still uptrending, along with persistent fever spikes. So we took over the patient in view of hyponatremia and complicated UTI with continuous high-grade fever spikes. And we hiked up the antibiotics after looking at the cultures. So the cultures were growing E. coli and Klebsiella, which was sensitive to meropenem. So on examination from our side, the pulse rate again was 100, BP was stable, respiratory rate was around 24, saturation 98 on room air, and a temperature of 101. On general examination, there was pallor present and bilateral pedal edema. Systemic examination, again, more or less, it was all systemic examination was within normal limits. Her sensorium was fine. Pupils were bilateral and reactive. Motor system, her tone and bulk was normal. Upper limb powers were 5/5. Lower limb post procedure, we did not assess. Sensory system was normal. Reflexes were 2+, and cerebellar signs could not be assessed. So these were her labs on the initial, the day when we took over. As you can see, her inflammatory markers were high, procal of 11, a CRP of 328, ESR of 60, and along with that, a hypoalbuminemia as a negative phase reactant, and a slight transaminitis, ALT more than AST, probably sepsis related. Uncontrolled sugars with a HbA1c of 7.9, hyponatremia of 127, potassium of 3.2. Her thyroid functions were within normal limits, and total counts were around 46,000, neutrophil predominant, and with the anemia of HB of 8.73 and a platelet count of 90. Her urine routine revealed numerous pus cells. Her serology, the anti-HCV, HPSAG, and HIV titers were all non-reactive. Her PTINR was also within normal limits. So since there was a high total count, we had gone for a peripheral smear, which did not reveal any atypical or blast cells, taken it as a leukemoid reaction itself. And this is our initial X-ray on admission. In the left lower zone, we had a very slight haziness which was present. So we continued the patient on antibiotics, but despite us giving meropenem, the patient continued to have high-grade fevers, tachypnea, and tachycardia, despite being on culture-sensitive antibiotics. So further, since the inflammatory markers were uptrending, we hiked up the antibiotics to ceftazidime, avibactam, and aztreonam. And following this, the next day, this is acute 3 to 4 day history. The patient had a decreased verbal output and decreased movements in bilateral upper and lower limbs. Her GCS dropped to E4, V1, and M1. At that point, while examining the patient, her vitals were as follows. There was tachycardia present. There was also a desaturation to 90%. Her CNS examination, pupils were bilaterally equal and reactive. Motor system, the tone and bulk was normal. There was no muscle atrophy or any fasciculations. The power in bilateral upper and lower limbs were 1/5. Sensory system could not be examined. Reflexes were present but diminished. There was no neck stiffness. Respiratory system examination also revealed reduced air entry in the left mammary region. So the patient was initially started on minimal oxygen for this desaturation. We took an ABG. ABG was showing a type 2 respiratory failure. We attributed that to the OSA. She was a obese patient. So we started her on a BiPAP. And at that point, with this drop in sensorium, we were thinking, could it be an acute stroke? Or given the type 2 respiratory failure, could it be an exacerbation of OSA? She had a multifactorial encephalopathy as well. Septic component was present, and the hypercapnia, or possible aspiration pneumonia. Given the tachycardia and the desaturation, we are thinking in terms of pulmonary embolism or an acute cardiac event. So we went ahead, we've taken repeat ECGs, which is not showing any fluid overload status or any obvious patch. We did a CT brain, and the CT brain also did not have any bleed. Furthermore, we went ahead and we had done a CTPA. So there also there was a slight pulmonary hypertension. Apart from that, no obvious pulmonary thromboembolism. So all the cultures that we sent by then had come back. The blood cultures were all negative, but the patient still continued to have fever spikes. So we wanted to rule out any other sources of sepsis. So we went for further imaging in the form of a CT abdomen and pelvis. Again, that came back as nothing suspicious. Everything seemed all right. We did a screening echo as well, which was normal. Cardiac enzymes were negative. D-dimer levels were sent, which was slightly elevated. However, since the patient was immobilized, we started on a prophylactic dose of anticoagulation. So further, the next day, what happened is the ABG showed worsening even on BiPAP, worsening type 2 respiratory failure. So the patient was electively intubated at that time. And we went ahead and we got an EEG done, which was also did not show any abnormality. As the patient continued to have fever spikes, at that point when we clinically examined the patient, we felt there was slight neck stiffness. However, we couldn't assess the Kernicks. Possibility of meningitis was thought, and we went ahead. Given the poor sensorium and other sources of sepsis could not be isolated, so the patient was also taken up for MRI brain with contrast before we did an LP. So we did a CSF analysis that also was within normal limits, did not reveal any meningitis. Along with that, since the patient was on the ventilator, we had sent some bowel cultures, all of which also reverted back negative. So at this point, the labs were something like this. The inflammatory parameters had come down. Her CRP was 14, procal from 11 came to 0.8. Hypoalbuminemia was persistent, and sodium of 153 because she was on a ventilator, potassium of 2.9, and total counts around 34,000. So repeat urine routine just showed 4 to 6 pus cells. We sent repeat cultures, that was also negative. So we knew the antibiotics was working, but still the patient had a poor sensorium. With the normal CSF analysis, went for an MRI brain with the spine screening, also did not show any obvious abnormality. So yeah,
Make it a little more
sure, sure.
guided consultation at this stage.
No,
Yeah, elderly lady with prolonged fever.
yes.
That's one point. And please don't say this is just for the postgraduate exam.
Hmm.
Please don't say air entry.
Okay.
Please say intensity of breath sounds. Because we had a professor who used to say air entry. If there is air entry, there will be air exit. And there, that air exit is not in the lungs. It's somewhere else, down there. Yeah, please continue.
Okay. So this was the timeline when July 16, the PFN was done. 19th was taken over to our department, and 23rd she had the desaturation and along with the investigations. So at this point, as no other primary systemic cause could be found out for the underlying respiratory failure, we thought of a possible neuromuscular junction involvement. So we went ahead, we got an NCV with RNS and a myasthenia panel which was sent. A CNS paraneoplastic panel was also sent because after consulting neurology, we immediately got our anti-ACH and anti-MuSK antibody receptors, which came back negative. So here the NCV study, as you can see, the RNS was within normal limits. It did not show any decremental or a variable response. And the other studies were showed evidence of a severe axonal polyneuropathy affecting bilateral upper and lower limbs. So this was in consistence with a critical illness polyneuropathy kind of a picture. So at this point, do you all know what a red herring is? Yes. So it is something something else, yeah. So it masks what is the underlying thing. So this patient having fevers, a UTI, and a fracture, and the surgery, all of this had masked what is underlying. So here, what we did is, since we were stuck, we went back to the bystanders. We retrospectively took a history again, and what we found out is what happened during. Why did the patient fall? What is the days leading up to the fall? So she had these complaints progressively over the last 6 months to 1 year, where she had difficulty climbing up the stairs, squatting, and she also complained of weakness, which was increased during the daytime, which got better while she took some rest. And she occasionally also complained of some dysphagia like symptoms, but none of them took it very seriously until she had this fall. There was no history of any ptosis or diplopia. So, based on this, what we did is we went ahead and we gave a neostigmin test, and 1 mg IM neostigmin was given. Flicker of movements was observed in upper limbs. So, empirically, we started the patient on pyridostigmin. And subsequently, also on a low dose DEXA, steroids were added. Post this, what happened is what we noticed is the fever spikes started coming down. So we were kind of certain that there was some autoimmune pathology underlying. And by then, the remaining panel report had come back. So this patient was positive for an agrin antibody from the myasthenia panel, along with the striational antibody, which was mildly positive. So, agrin antibody and striated muscle antibodies. So, when you get these antibodies positive, is something called as a triple negative myasthenia, where your traditional anti-acetylcholine receptor, anti-MuSK antibody, LRP4, all of these are negative. In an old-aged individual, we can have some of these antibodies which can come positive. So, agrin is again steroid sensitive. So mild intermittent movements of upper limbs were seen, and we consulted neuro and we started the patient on a course of IVIG. So 2 mg per kg over 5 days. At acutely, there was no improvement in any motor activity. So here, one issue that we faced is we have this underlying myasthenia, which was steroid sensitive, and up and coming, the new topics is the critical illness polyneuropathy. So all the research and studies on critical illness polyneuropathy points towards steroids worsening the underlying condition. So we had to find a fine line between whether to start or hike up the steroids. So we went ahead and we hiked up the steroids, and we could slowly then wean off the patient off the ventilator. Tracheostomy was done, and she was shifted to a BiPAP. And then later on, spacing of BiPAP was also achieved, and she was shifted out to the ward. So, what I would like to discuss here is myasthenia as such. Causes for myasthenia, if you see in a broad, 10% of them is due to a paraneoplastic disease. Remaining 90%, which are all these ACH, mask antibodies, LRP4, not the definitive cause is known. So, genetic factors are also less than 50%. So in this condition, she had an infection. So there are a lot of studies which are suggested in not just myasthenia, in autoimmune disorders as such, where infections play a major external cause in triggering these events. So, for example, and this post-infectious autoimmune disease, well established in demyelinating polyneuropathy, where Campylobacter jejuni is a culprit. So, no such link has been formed with a particular infection and myasthenia as such, but it is a new hypothesis that infection triggering or a stress related triggering of this myasthenia crisis. So, some more things that have, in myasthenia, what we expect on RNS a decremental response. But here in our patient, they had got a normal response. So, it depends on the technician, and you might also get a negative response. So, triple negative myasthenia, as I said, anti ACH, anti MuSK, and anti LRP4 is negative. So, these are late onset myasthenias, which usually have a limb involvement rather than your traditional ocular and bulbar involvement. So, this may or may not be associated with thymomas. So, in late onset, you get these titin rhinodin antibodies. Those are striational antibodies. So, the myasthenia crisis, as you all know, is a rapid and severe deterioration of myasthenia, which requires a respiratory support. So, when you talk in terms of treatment of myasthenia, you have your short term treatment and you have your long term treatment. So, your short term treatments is where you prefer to give your IVIG or a Plex. That is, where is it indicated? In a myasthenia crisis, or if you're preparing a patient for a surgery with a severe bulbar dysfunction, or if you want a rapid response to the treatment. So here in these conditions, you would prefer to give a Plex or a IVIG. So for a long-term treatment plans, as of now, they go with calcineurin inhibitors plus or minus steroids. So and upcoming monoclonal antibodies that they use right now based on anti-CD5 or anti-CD20, that is eculizumab and rituximab. These have been used for long-term therapies. These are some conditions which can mimic a myasthenia. As you'll know, ALS, pure motor, like on the level of anterior horn cell. Botulism, again, it's a presynaptic rather than a postsynaptic NMJ. GBS, which is your ascending limb paralysis following an infection. Lambert-Eaton syndrome, again similar to myasthenia, which is a presynaptic against the VYQ channels. Here on RNS you get a variable response, and on high frequency testing you're supposed to get a incremental into 100 response. So these are some common drugs that we use on a day-to-day basis, D-penicillamine, and something from the previous topic that we just spoke about on the back of my head is on antacids, whatever magnesium component is there. Magnesium is known to trigger myasthenia. And your antibiotics, your aminoglycosides, ampicillin, ciproflox, erythromycin, and your beta blocker, propranolol. Okay, so that's my topic. Thank you.
Thank you for the nice presentation. Did you examine or get examined this patient's breast?
Yeah, we did actually examine the breast.
For
There was
what?
no lump as such.
So when you get a lady patient, they are exclusive for a few things. One is gynecological issues.
Yes,
Second one is breast. And the third one is autoimmune diseases.
correct.
This is the classical teaching. So if you're going for MD exam, when you see a lady patient as your case, Please remember these three things
Sure, sir.
as an independent category. So you got the mammogram also, because you're talking about paraneoplastic.
At this stage, I couldn't shift her for a mammogram.
But you have sent her to almost
Yeah,
entire Amrita,
that's true.
all the floors and all the blocks. I know all the blocks because I was a professor there in
Okay.
2004 and 5,
Okay.
medicine professor, primary school teacher.
Okay.
Not or they have come to your ward, so you've consulted most of them. So please remember this:
Sure.
gynec and breast in all such complicated cases. That's one simple clinical point. Thank you.
Fracture with sepsis, with a loss of deteriorating sensorium.
It was not a immediate. Yeah. No, it's not common to. You have a bimodal peak in myasthenia, but as the age progresses, I think males are more affected than females. One is the rapidly deteriorating respiratory crisis that the patient had. Yes, yes. Sure.
Any clinical clue. Suppose next time a clinician is seeing the patient, he should think of myasthenia in that case. So is there any specific marker, any specific clinical sign, any symptom which suggested of a difficulty in getting up a stairs, 77-year-old, 90-year-old patient, 90 kg patient, difficulty in climbing stairs is a very, very vague symptom. And second thing is that immediately suspect myasthenia at an age of 77 without any preceding history. She came with a fracture, it was treated, she went in for sepsis, then came down, she went in for hyponatremia, which was corrected. Again, she went in for a comatose state, a sensorium deteriorated. So in this context, what was the pointer towards myasthenia?
So there was nothing evident as far as myasthenia is concerned. As was already discussed, it usually starts off with ocular myasthenia is the most common. Only some of them, after 3 years, they progress to generalized myasthenia and whatever entities described. So basically, why we reached up there is patient had a limb weakness, bilateral limb weakness, which couldn't be explained by any of the common causes. Like we did an MRI, we did a CT. Patient had a hypokalemia initially, which was severe, but by the time when she developed the weakness, the potassium was almost corrected. She had going by the protocol of evaluating a lower limb weakness, element type of weakness, anterior horn cell was immediately ruled out because she didn't have fasciculations, wasting, those kind of things. So the only stations that was left is muscle and myoneural junction. Muscle, again, the intermittent weakness because of channelopathy, because of hypokalemia, rhabdomyolysis, Duchenne muscle dystrophy. It's a congenital. It should have been present from an earlier time. Drugs like statins, hypothyroidism, all of the things which could have caused a sudden lower limb weakness was, and even though myasthenia is not, we had ruled out all the common causes that could have, she was not moving her limbs. So that was what led, and that's why we did an NCV. And when the NCV was done, it was suggestive of a critical illness neuropathy. It was an axonal type of sensory motor neuropathy. So that is, we had got stuck at that particular point. And this is a very extreme rare form of myasthenia with this anti-agrin antibody, because myasthenia is neuromuscular junction disorder, especially myasthenia or whatever condition. The primary thing is it has to have an ocular involvement, and or it has to progress to a pharyngeal bulbar, this kind of a thing. There's a very, very atypical presentation, and we have consulted the neuroimmunology department from Amrita, Dr. Sudhiran. So sir was the one who suggested that a rare form of myasthenia, this can occur. So as you said, it is not at all something that we have to. It was like after ruling out all the primary causes that could have caused the limb weakness along with the respiratory. No, she's just suddenly stopped moving the limbs along with having the type 2 respiratory failure. She was not moving any of the limbs. And it was not because of the pain. Even to pain, she was not moving. She had both proximal and distal muscle weakness of both the upper limbs and lower limbs, for which we didn't have an answer.
So can myasthenia present like that?
It is very rare. The one with
it can't present as a distal weakness, right?
Yeah.
Myasthenia,
Yeah.
acute presentation
Yeah.
with the proximal and distal weakness, unlike it.
Yeah.
That too, agrin is very, very, very rare.
Yeah.
Common is the acer receptor muscardis. That
Yeah.
too, it is usually a subacute evolution.
Yeah.
Proximal more than distal.
Exactly.
Bilaterally symmetrical.
Yes.
This distal movement might be due to uncontrolled diabetes, which might be there.
Yes.
Polyneuropathy might be due to the uncontrolled
Yes.
diabetes that might be there.
Yes.
So it is very, very confounded that got an agrin positive, but case pyridostic mean any case you give, it can act as a mild stimulant agent, but that doesn't.
It just increases the acetylcholine in the.
Say that, and DEXA when you get.
Yes, definitely.
In that, actually might be coming wrong, but in this case, it's very, very, very tough because there's so many controlling factors in this. It's actually the myasthenia at the age of 77. That person after hip fracture, it is very difficult to digest.
Yes.
Present situation, she's on spacing of BiPAP. No, now she recently got discharged, like maybe 2 days back. She's now currently she's gone home on BiPAP itself, on continuous BiPAP.
That made it even more difficult because
Dr. Kiran
I was also in the
he was
team
in
at
the
that time.
managing team of the patient.
The granddaughter is actually an anesthetist doing her PG. So each and every thing we do has to be justified. And as you all know, the questions that would come. So we were actually pushed to the wall, and we were looking for whatever answers we could get. And at that time, it worked. Yes, yes. And at that time, this worked. Her fevers came down. She got better. They are happy. We are happy.
I really thank the team from Amrita for that.
Thank you, sir.
Time
Thank you, sir.
going. I think he'll